and knowledge shared is power multiplied. So here we are getting more empowerment. So I would like to request our chairpersons to please come on stage. First, I would like to invite Dr. Lalita Shukla ma'am. She's a senior obstetrician and gynecologist of Prayagraj. Dr. Amrita Churasia ma'am. She's HOD Ops and Gynae Department, MLN Medical College, Prayagraj. Dr. Urvashi Barman Singh. She's professor and head, United Institute of Medical Sciences. Request one of the chairpersons to please introduce our speaker, Dr. Mandakini Pradhan ma'am.
Good afternoon. First of all, I want to congratulate the organizing team for selecting such a good topics and wonderful speakers. Previous talk was very good. And as we know, field of genetics has implication in our everyday life. Basic concept of genetics help us to understand hereditary, DNA and genes and all genetic diseases. In the past, scientists used to work on pea plant to understand the genetics. Understanding genetics, how it play a role in the past, present and future, help us to understand better understanding of ourselves and those around us. For this topic, we have very good speaker, Professor Mandakini ma'am, and I think in UP no one is better than Dr. Mandakini. Madam is MD Obs Gynae, PG, PGI MER, Chandigarh, DNB, DM Medical Genetics. She is professor and head, SGPGI Institute of Medical Sciences, Lucknow, Uttar Pradesh. She has many publications, unaccountable, and she is chairperson of Foxy Genetics and Fetal Medicine Committee, 2019 to 2022. She received Bharat Gaurav Saman 2020 by World Human Rights Protection Organization, Women Achiever Award 2021 by Government of Uttar Pradesh. Madam, now.
Yeah. Thank you so much, chairperson. And good afternoon, everyone. Respected seniors, my dear colleagues. I am here before you to talk something on genetics after such enlightening talk on moon mission by ISRO scientist and a transplantation surgeon. Actually, I am flattened after listening these two talks. AI went above my head and this has paralyzed me. How many hours he must have spent his life, if he calculates the percentage of hours that he has spent in doing this surgery, it will be definitely more than 75% of the time. I have asked him to do that. So here I am talking about something which is post-lunch and genetics, definitely some amount of boring will come. So your reaction may be like this, running away, but then things have changed. We start looking at genetics, medical science, what is this boring? But the current scenario is that we definitely, even if we are old, we start thinking about at least let's know something about genetics which has come into our routine day-to-day clinical practice. I'm not going on to this past of all this history. We know about at least the green pea, this thing of Mandel, and what we know is every cell has got 46 chromosomes, 44 are autosomes, 2 sex chromosomes, what differentiates between male and a female. In our MBBS days, at least those who are of my age must remember that we used to do buccal smear to know about the sex, and where do we apply in clinical science? We used to collect this buccal smear, then put it into to see for Barr body, and then that was being used for suspected Turner syndrome, Klinefelter, any babies with ambiguous genitalia. Like I worked in All India Institute, there also we used to send buccal smear. For that was our past of genetics. Then came chromosomal analysis, collect a blood in heparinized vial, isolate lymphocytes, that exactly lymphocytes cannot be isolated. The buffy coat is collected, then put into culture. So you have got dividing cell, and these dividing cells are live cells, and they are arrested at certain phase. They are spread onto a slide so that they are long and non-overlapping, and GIMSA stand and looked into under a microscope. This is what is under a microscope looks like the chromosomal analysis of karyotype, what we say, and this is what is on zooming. It looks like the second one, this one, and then we analyze them whether 1, 2, 3, 4 they are in pairs, and this is what is chromosome analysis, which came first. And what is the advancement presently is that the same slide is being put onto a microscope, which is with some amount of artificial intelligence. They analyze which are the chromosomes they are there, and of course it is added on to your human brain, and the final analysis report is created. So let's come on to genetics. That was the past genetics, buccal smear and karyotype, the initial phase. The next came on to the present scenario of genetics. If you look into your class 12th biology book, you will have a content, and if you go through the content, then you will definitely find the genetics volume, the 2 chapters on genetics, human inheritance and biotechnology. So it starts, our genetic knowledge starts from class 12, and our anatomy, general anatomy, along with genetics, histology and embryology are clubbed together. So we have to know it, and probably the younger generation must be knowing it. But let me clarify it as per our application in day-to-day clinical life. So it's all the genes are, let's take that example of looking into books in the library. Can you make out any books in this library? No, you cannot. So if you try to look into genes in your chromosomes, it will be something jumbling like this. So then your reaction will be something like this. This thing you can't make out. So if you arrange them into pathology rack and then anatomy rack, physiology, you will make out something out of it. Then what do? It is exactly akin to the chromosomes that you see under a microscope. Now what I have done, I have arranged the anatomy, physiology, biochemistry, pathology, microbiology and all these books, the library racks, onto pairs. So now I can make out whether if there is any defect or there is no defect. If I found, and then I number them. So this is how a chromosomal analysis is done. If I find that instead of 46, there is one extra chromosome on chromosome 21, commonest syndrome, trisomy 21 Down syndrome. So similarly, if one is extra in 18 or one is extra in 13, so trisomy 13. These are number extra, and this is how a chromosome analysis helps you. So it is grossly, it looks into how many chromosomes are there of a chromosome of interest, and the test that performs it is fluorescent in situ hybridization, or in short we call it as FISH, not the fish that we eat. So that is FISH for chromosome 21 or 18 or 13. Another test is also there, qA-PCR, which I am not going on to detail. There can be 69 chromosomes, so all chromosomes are 3 in number, and that is in a partial mole, or the baby is there and the fetus is there and the placenta is hydropic, and we call it the partial mode. The anatomy books or pathology books got shifted onto, unable to see this, if you see the chromosome 4 and then chromosome 12, so there are some exchange of the books in these. Say for example, medicine book has got onto pathology and pathology has got into medicine. There is no loss or gain of books. So what is called as a balanced translocation. Exactly in chromosomal word, it is called as a balanced chromosomal translocation, or balanced translocation of books. So it is balanced chromosomal translocation because there is no loss or gain of any genetic material. So this is, we commonly find in a couple who has got history of previous stillbirth, previous recurrent spontaneous abortion. So this is what is, but if I am looking into the racks, they are normal. So what, but the condition is something which is abnormal, or the baby or the newborn, or they have got something which is abnormal. I am not finding out. So I know that I have looked into the racks. I have not gone and looked into the pages. So let me look into the pages. So now I have opened all the books present in the lab in the library and look into every page. So the page is, say for example, 49 and then after that 51. So what has happened is 50 is missing. Here is a deletion, or 50 then followed by 50. So here is a duplication. So a deletion or duplication of page has to be looked into, and the test that looks into this deletion or duplication is akin to few words, line or paragraph, and that is called as a microarray. So our first test is chromosomal analysis or karyotype. The next is microarray. Here is a baby who was developmentally delayed, chromosomal analysis normal, but the baby is symptomatic and mother is pregnant and wants to know if the subsequent pregnancy will be affected or not. That's a common situation that we deal every day. So the baby's microarray shows deletion. So we have found out the cause of her the mental developmental delay. So what are the indication? Fetal malformation. We definitely, if chromosomes are normal, then we go on to microarray. Stillbirth. We cannot have live cells. Chromosomes are for live cells. So we have to have a microarray. Invasive test done for some other indication. I am looking for something else, some other single gene disorder. The single gene disorder is normal. Then I can go ahead and offer this microarray to the couple. Previous mental retardation with normal karyotype, but however, before that counseling is essential, and as everyone says, probably artificial intelligence will come into, then patient will be counseled. Like we get very less time to do this counseling. So we get reports like whether it is pathogenic or a variance of unknown significance. Parents are analyzed. I am not going on to detail how do we say. But if your ultrasound there is abnormality, karyotype is normal, then if I am doing a microarray additional test, I am getting 6% fetus being abnormal in microarray, which will go unnoticed, and then these babies will be manifesting after birth. And similarly in normal fetus. In our experience also, our series also, almost more than 90% people they accept microarray as addition to karyotype, and then around 4% we are detecting abnormal microarray without any fetal malformation. So we offer them to all patients. Now I have looked into the pages of the books that are there in the library. So after 49 it is 50, so there is no loss or gain of pages in the book. So I definitely look into the baby is abnormal. I have not found out the cause. So I definitely go further in to look into the defect or to try to find out the defect. So what is it is reading every line of the book, and what is it is reading every word, or in genetic word it is called as a sequencing. And say for example this line sentence what is written is every house should have a toilet. So now let's take this toilet, and toilet is I is missing here. So what it reads is every house should have toilet. So every house is for letting. So and then every house should have omelette. So changing 3 words changes the absolute meaning of the word. Similarly, in genetics, changing few words, replacing, deleting, or change of any base pair leads to change in amino acids and leads to change in protein, and hence the manifestation in the baby. So you need to look for it, and the test that looks for it is gene sequencing or the whole exome sequencing. So let's come on to few cases. So we, as a clinician, we should not forget, like today the oration, Dr. Divan was saying that we are moving away from our touch. We are moving away from past history and present history. That's very sad. This is a patient, 10 weeks, previous child with developmental delay definitely came. That previous pregnancy she had lot of ultrasound, everything normal. Baby weight was 3 kilo, upcar was abnormal. Baby had jaundice detected at day 7 of life. And then maximum bilirubin was 38. Phototherapy 4 to 5 days, no exchange transfusion. Baby had seizure on day 11, discharge day 14, 1 year bilateral sensorineural hearing loss, 2 year MRI, mild diffuse and cerebral atrophy, 3 years cochlear implant. So cochlear implant means baby has gone to some higher center. 4 years bisyllables works with support. Mother is again pregnant, wants to know if there will be recurrence. What is this? Baby already have got this test done. Chromosomes normal, microarray normal. It's a male baby, so somebody has tested her Fragile X. It is normal. Currently 4 years. So this is her microarray report and the Fragile X report, which was normal. If you see this video, sorry, yeah, how to play? No. Yeah, this is the child that this thing, second pregnancy, booking at 10 weeks, first antenatal visit, very educated patient. See, you can see that this child is unable to walk. So neonatal jaundice, seizure, sensorineural hearing loss, developmental delay. You try to think about ABO blood grouping, mismatched blood group, then do a ICT, sometimes minor blood group mismatch. Then next set of line of treatment is G6PD deficiency, male baby. So G6PD was 30, counseling done, G6PD gene sequencing was ordered, baby was found to be G6PD deficient on gene sequencing. Mother was tested, mother was a carrier, then targeted mutation was done and mother was found to be a carrier. So accordingly we could able to counsel the couple and then we could offer them a prenatal testing. The fetus was a carrier. Then what is management? It is not termination of pregnancy. It is giving counseling and then we informing the neonatologist that such a baby is coming up. You should not give all these drugs, that is the list of drugs that is not to be given, and these babies will be absolutely normal excepting few precautions. So coming on to the next case where I try to elicit a family history. Referred at 13 weeks that her trisomy 21 risk was high risk on some serum screening. So but then we forget to take a family history. Here is the family history. The mother who was pregnant, her brother has got developmental delay. If you can see this brother of the patient who is wearing two different color slippers and is not looking at the photography, and then it was very difficult, with lot of difficulty we could able to get this photograph at least. They did not bring the child for examination. So motivated for investigation. In investigation this was found to be Fragile X syndrome. Karyotype was normal, male, mental retardation, you look for Fragile X and he was Fragile X. Then the woman was tested, brother of a Fragile X, sister of a Fragile X patient. So X-linked, so the mother was carrier, the woman was carrier, then it was tested, the fetus was tested to be carrier. Apart from trisomy 21, we also simultaneously looked into Fragile X. So then ensuring your a healthy baby coming up, fetus, Fragile X carrier, they continued the pregnancy and then the baby is fine. So what is learning from this? Take a good family history and your past history. In your busy OPD, at least write something about family history of mental retardation, malformation, infertility, recurrent abortion. That will probably sort out many things. So family history of mental retardation, they go on examining, and then so here are some cases whereas 4 male loss and then 1 baby who had absent nipple. So then you start thinking it is definitely there is some amount of genetics, and because recurrent loss and all of them are male. The female who is there has got some abnormality of the ectodermal component and hence ectodermal dysplasia. The mother on examination had some amount of difficulty, so there was absent teeth in the mother, so it was X-linked ectodermal dysplasia which can be inherited, and then subsequent pregnancy accordingly can be managed. So similarly, short, long bone, short stature, the baby was being given growth hormone for growth hormone deficiency. Just see. And then on X-ray, examining those X-ray which were available with the patient itself. No fresh X-ray were done. one can see multiple small calcifications, so chondrodysplasia punctata, which is inherited and can be done with a gene sequencing. Fetal hydrocephalus, a closer look, if somebody is a radiologist, good radiologist will look for adducted thumb. The baby was delivered because it was advanced gestational age, and one can see that the baby fist is closed with a hydrocephalus. Then you look for, do a gene sequencing, and then you identify, you do the mother being carrier, and then fetus subsequent pregnancy, you can ensure the couple to have a normal baby. So examination I probably need to leave it, and then we go on to the investigation. A patient who was sent for cholelithiasis, mother was moderate pallor, hemoglobin HPLC was done, is a software engineer, moved on to Pune, looked into online, she looked into her reports of ACPGI, and then she thought that it is normal, which was abnormal, interpreted it to be normal, then reported it, then she shifted back to Lucknow, then reported at 32 weeks. 30 weeks. Husband was tested, husband again was found to be thalassemia carrier. And the story doesn't end there. Baby was delivered, she was already 32 weeks. She delivered 9 months ago. And now the baby is thalassemia major, is on transfusion. So this is how our knowledge can translate into having a good outcome in antenatal period and then subsequent the neonatal period. So antenatal investigation should be done in appropriate time and should be interpreted appropriately. Always prevention is better than cure. So try to prevent with these genetic tests that are available, and the most important thing is that we need to be aware about the testing that are available in India. All tests are now these days available, they are becoming cheaper, so one can opt for it. So that is why I always write that antenatal care provider is responsible for giving birth to a thalassemia major child. And if you know that how many units of blood is being consumed by thalassemia major for transfusion, then you will be astonished. Many liver surgery can be transplantation. Of course, they are doing bloodless surgery. They don't need, but then all the rest of the surgeons will need surgery, blood for that. So that can be done. A child of multiple fracture, closer look, mother has got blue sclera, and then on examination it is osteogenesis imperfecta. Subsequent pregnancy again affected, fetus was affected with osteogenesis imperfecta, and then mother on closer examination showed fracture limb and deformed hand later on when we had a subsequent examination. So what by this thing is that you have to examine the woman properly so that you identify all those clinical clues so that you can advise your lab to do the test. Do not depend on the lab to tell you that it is osteogenesis imperfecta unless until you tell that the patient has got multiple fracture. So chromosome, I told about karyotype, then microarray looking into pages, and then whole exome sequencing looking into lines and this thing. So there is some other test called MLPA, I am not going on to detail. So the present is karyotype we do for recurrent spontaneous abortion, any malformation, infertility, couple with infertility. Microarray we do for stillbirth, and if karyotype is normal in a malformed fetus. Whole exome sequencing for other causes like mental retardation, unexplained stillbirth, malformation, skeletal abnormality. Malformation, we think that it is malformed, so let us discard or terminate the pregnancy. But no, you begin your investigation there. If you detect the defect in that malformed child, which is easy to be detected, then you can manage their subsequent pregnancy in a better way. So fees for specific chromosome, MLPA for DMD and SMA. So the practical tips of collection of blood: 2 ml blood in a heparinized vial for chromosomal analysis, 2 ml blood in EDTA vial for microarray, 2 ml blood in EDTA vial for whole exome sequencing. These are all DNA tests. And tissue in formaldehyde are not good for DNA test, and hence If your tissue is preserved in formaldehyde or formalin, please do not order a whole exome sequencing from the lab. So future, so I have talked about present, I have talked about past. What is the future? Probably in future, screening of couple by whole exome, all patients will be screened. Maybe whom to screen, we are confined to all these previous mental retardation, congenital malformation, stillbirth. Maybe all couple, maybe consanguineous couple, we are not very sure about it. The literature are coming up little into it, but not very clear. Screening of fetus by whole exome sequencing. So all our future generation are screened by whole exome sequencing. All their genes are perfect. So that is a dream probably, and maybe if the test, the cost of the test decreases, probably couple may be opting for it, which we do not encourage it. So all abnormal pregnancy is not genetics. I've got few, this is exophthalmos, one can see, so thyrotoxicosis, and then fetal hydrops. So it should not be thought about genetics. Next, so it is, the treatment is antithyroid. The rash on the hand, on this is non-genetic. So it is skin examination. So it is SLE, systemic lupus erythematosus. The medicines can cure, and maternal fetal monitoring. This is common erythema nodosum, and because of tuberculosis, so the treatment is anti-tubercular, not genetics. So this is some hypopigmented rash, the skin depigmentation of one side of the face, then hand. So these are all non-genetic. Hansen's disease, pregnancy. So you need to treat Hansen's, not whole exome sequencing. So definitely genetics has come to routine obstetric practice, but as a clinician we should not forget our history taking, examination, and proper examination. A healthy child is obstetrician's role. They look to this mother 4 to 40 weeks and keep updating yourself. It's definitely upcoming. Next 10 years will be genetics, and your obstetric practice will be changed from delivery to a healthy fetus. So after this lecture, I did not do it. Anyway, I thought of animating it, forgot it. Anyway, it's boring, very difficult, not useful in clinical practice, can only be done in research setting. Will advise all patients attending my clinic. Useful but need to know more. Only a topic for a talk in AMA. AMA thought that it is something upcoming, and then call Dr. Mandakini to talk about it. You can decide and take yourself, and then so join hand, and so that we can work better. Thank you so much. And thank you AMA for calling me, giving me this opportunity, meeting people, and then talking about something which I love to do.
So thank you, Dr. Mandakini. It was really enigmatic and spellbounding lecture by you. We always knew you because the whole UP depend upon her for genetics, all the obstetricians. So I must congratulate you, and I must congratulate the whole team of today's CME to have you here. Madam, you are really true, because by the time gradually being a teacher at a medical college, everybody will agree that the art of history taking, the past history, the personal history, the family history, it is going on vanishing and vanishing. Everybody is depending upon only the investigations. And for the fact, I must say, they don't know even how to interpret those investigations and how to correlate them with their clinical history. So emphasizing that is very important, and understanding genetics is very important, because sometimes you are helpless, but sometimes you are really able to help the patient, and at least you have something to counsel them, to at least you have something to explain to them. So thank you so much, ma'am. I will discuss one patient of mine. She is parity 0+6, 6 abortions she had. So I'm going to refer her to you, but I'll talk to you. Yeah. Thank you, ma'am.
Thank you, Dr. Mandakini. Your talk was definitely not boring. I mean, at least I enjoyed it a lot, because we get many patients with such histories and we are bound to think what to do with them. Ultimately, we do refer them to you, to SGPGI. Another thing is I wanted to ask you about consanguineous marriages. Like I had a patient who had 3 successive children who were all affected in some way. So what would you advise in such cases? Well, he came to me after 3 children and then they were married, they were cousins. They were sisters of, I mean, children of brother and sister. So they want...
Consanguineous couple.
Pardon?
Consanguineous couple.
Yes, yes.
Yeah.
And they, after 3 children, they thought about it. I mean, they were wondering what to do.
3 normal
Affected.
children.
They were affected in some way or the other.
Yeah.
They were, I mean, not very
So
normal. So they wanted to know what to do now in case they want to plan a 4th pregnancy.
First step is karyotype, second step is whole exome sequencing of the couple. If the affected children are alive, then one of the most affected child to be tested first. And then we have n number of patients like this, and we are coming up with our analysis of looking into whether we apply this whole exome sequencing to look for common carrier of autosomal recessive condition in both the parents in a consanguineous couple. What we recommend is we have to do a whole exome sequencing to look for autosomal recessive carrier in a consanguineous couple, definitely. So this patient will definitely has got a dead. So he can move with one affected child to our center. We will send a sample.
So in future, I mean, they have to get all the tests done before getting pregnant or after the baby is conceived?
No, before getting pregnant. We run a preconception clinic to look into such cases and then test them and then counsel them that if we identify the defect, then the risk of recurrence is 25%, 75% chance that they will have a normal baby. And we can do a definite prenatal diagnosis is possible, doable at 12 weeks of gestation.
So in such cases, would surrogacy be advised in case they really want to have it?
We do not encourage surrogacy unless until the couple opts for it. We encourage them to have testing, identification of mutation, testing, and then having 75% chance that you will have a normal baby.
Thank you.
We encourage them.
Okay, thank you.
Yeah, thank you. Thank you so much.